Hello, I'm Gabriella Pridjian. I'm a clinical geneticist in the Hayward Genetics Center at Tulane University, and I'm also an obstetrician gynecologist and a maternal fetal medicine specialist. I was asked to give this medical commentary because I take care of women who are pregnant and have PKU. Let's briefly review what happens with no therapy. Phenylalanine crosses the placenta by active transport, as many of the amino acids do, important for protein development in the fetus. In uncontrolled maternal PKU, elevated phenylalanine and its metabolites cross the placenta and interfere with embryogenesis and fetal development in the second and third trimester as well. The mechanism of maternal PKU embryopathy, or exactly how the phenylalanine interferes, is still unknown, but we do know that it happens. Nearly all newborns of mothers with untreated PKU have some degree of embryopathy. This was seen in the original study of Lenke and Levy in 1980, where they showed that 92% had intellectual incapacity or developmental delay, and many had microcephaly, low birth weight, congenital heart disease, and other malformations. And these findings were also confirmed by more recent collaborative studies. Good metabolic control prior to and during the first trimester of pregnancy reduces the malformation risk to the fetus, and control in the latter trimesters also helps reduce the risk of developmental delay. However, management of maternal PKU can be challenging even in PKU mothers who continue or resume a strict diet during pregnancy. Sustained adherence to restriction of phenylalanine during a pregnancy is difficult. Phenylalanine-free protein formula can be especially distasteful, and we all know the first trimester nausea, vomiting, and inability to eat can be extremely problematic. Maternal PKU can have its challenges. Unplanned pregnancy in women with PKU can expose the embryo to excessive phenylalanine, even before the pregnancy is diagnosed. We counsel girls about the birth defects associated with being in poor control, and we start this counseling around the time of menses. We repeat the counseling, we discuss contraception, but counseling isn't always remembered and contraception isn't always used. So conceptions with high maternal phenylalanine still occur. Second, the protein requirements in pregnancy can change to some degree depending on the trimester as well as the pregnancy itself. And finally, there's often catabolism in the first trimester. Women have nausea and vomiting with poor intake. And even if we control the nausea and vomiting, there still is insufficient protein intake to allow for growth. Therefore, there's endogenous protein catabolism, and the phenylalanine is elevated because of the endogenous breakdown of protein. We had a patient about 20 years ago who had classic PKU, and we couldn't bring her phenylalanine level down low enough, and she was barely eating anything and on diet. We finally had to bring her in the hospital and put a nasogastric tube in and drip phenylalanine-free formula through the nasogastric tube, which she tolerated. And in this way, we were able to decrease the phenylalanine level until she could eat exogenous protein herself. Maternal PKU treatment has followed general PKU treatment outside of pregnancy. Classically, protein-restricted diet with phenylalanine-free protein supplementation occurred, and we did this prior to pregnancy in the first trimesters and the remainder of the pregnancy. It works if one is able to maintain the diet and able to drink the formula during pregnancy, which is not always the case. Sapropterin has also been used in pregnant women to manage their phenylalanine levels. And finally, more recently, pegvaliase has been used. Pegvaliase is an alternate enzyme that metabolizes phenylalanine to ammonia and tranexamic acid, which are more easily excreted. Sapropterin dihydrochloride is a synthetic version of BH4, or tetrahydrobiopterin. The FDA approved this medication in 2007 for treatment of PKU. BH4 is a cofactor for the enzyme. Sapropterin responsiveness in PKU individuals is related to its function to stabilize mutant PAH. Approximately 56 to 75% of patients with PKU respond to sapropterin. We initiate at 20 milligrams per kilogram per day, follow their phenylalanine, and liberalize intact protein intake. Sapropterin comes in 100 milligram tablets and now a powder alternative in either 100 or 500 milligram packets. The powder is tasteless, and since it doesn't have the citric acid preservative as the tablets, the powder seems to not cause as much GI issues and can be tolerated better in some PKU patients. Our group and others have used sapropterin in pregnancy if women were clear responders. This is an example of one of our first sapropterin-treated women in pregnancy. She had difficulty with formula and couldn't manage dietary restriction alone. So we started her on sapropterin, and she did well during the pregnancy. It dropped her phenylalanine level to the normal ranges. She had a healthy newborn without malformations and without dysmorphology. The only side effect she had during the pregnancy is the first trimester nausea that we thought might have been pregnancy related, but we split her dose to twice a day instead of only daily. There are a large number of pills that she had to take. Her daughter is doing well. She had a formal developmental assessment at 7 months and at 2 years of age, and they were normal. She is now in high school. In May of 2018, Pegvaliase was FDA approved for treatment of PKU. Pegvaliase is a pegylated ammonia lyase enzyme, and pegylation refers to the attachment of polyethylene glycol to an enzyme, so it causes the enzyme to be cleared more slowly. Pegylation was also found to reduce immune reactions. Pegvaliase is a substitute enzyme for phenylalanine hydroxylase. It has 15 carbons, is of moderate size with some polarity to its surface area. The reason I bring these details up is that they are somewhat important in assessing new medication use in pregnancy. Pegvaliase is an injectable compound and must be given daily. It's provided in a prefilled syringe in doses of 5, 10, 20, 40, and now 60 milligrams. Treatment is initially induced with a low dose of the enzyme. Titration occurs to the response, and a maintenance dose is determined. During titration, intact protein is increased and metabolic formula is decreased gradually, and it may take quite some time for the response. There are side effects: chills, fatigue, rash, joint pain, injection site reaction, and less commonly, severe anaphylaxis. The pharmacokinetics of this medication is difficult to predict. There's high patient variability, likely related to different immune responses. Because of side effects and hypersensitivity, we premedicate patients with H1 receptor antagonists. We allow for longer titration periods, and they carry EpiPens or auto-injectable adrenaline. And if they have an event, we temporarily reduce the medication and then restart it a little bit later in the usual dose. So now we have reproductive age women on Pegvaliase and on an unrestricted diet. Of course, we would expect that someone would get pregnant. So what would we do? stopping the medication and returning to dietary restriction and phenylalanine-free protein formula supplementation is extremely difficult at this point. Basically, we're going from good phenylalanine control to very erratic and episodic control and risk to the developing fetus. Should we use it in pregnancy? What should we consider? These are some general concepts that our team used for assessing the use of pegvaliase in pregnancy. So we looked at its molecular size, it was moderately large, its polarity, it had some polarity, and the risk of transplacental passage. Pegylated enzymes don't appear to transport across the placenta easily. In animal models, we didn't see transplacental passage. And in human in vitro placental perfused models, other substances, other enzymes that were pegylated did not cross the placenta. Secondly, we assess the risks and side effects outside of the pregnancy, and if too great, we certainly don't use it in the pregnancy. Thirdly, we assess if similar medications, other pegylated enzymes, were used in the pregnancy and what their outcome was. There were some that were reported in the literature, but no specific abnormality of the fetus was noted. Finally, and the biggest concept is comparing the risk of not using the medication, that is high phenylalanine levels, to the risk or the unknown risk of using the medication during pregnancy. Clearly, the known teratogenic effect of high phenylalanine to us balanced the unknown risk of teratogenicity of pegvaliase. However, women should be an active participant in this decision. We do have one current ongoing pregnancy. This is our ongoing patient now who is on pegvaliase. Prior to pregnancy, she had a good response to the treatment. She was on 40 milligrams a day with normal phenylalanine levels on unrestricted protein intake. This was an unplanned pregnancy. We counseled her on the options for treatment, and the decision was made to continue the medication. We noticed a slight drop in her phenylalanine at around week 11, and we decreased her pegvaliase somewhat and then had to increase it later in the pregnancy. She is currently about 20 weeks of gestation. She had a fetal anatomy scan that was normal with normal head growth and no malformations. What to choose? What are the treatment modalities for maternal PKU? Whatever is chosen, the decision should be made among the patient, her dietitian, who really knows her well, and the geneticist. If she's committed, if the patient is committed and she can manage her pregnancy without medication, then protein-restricted diet, phenylalanine-free protein supplementation, and close monitoring would be done. Important is to optimize first trimester protein intake. If she's stable on BH4 or sapropterin, we would continue the BH4, follow closely with adjustments in dosing. If she's stable on pegvaliase, we would discuss continuing the pegvaliase, again, following very closely, and we may see that we may need to adjust. If she's not really committed and not on any medication, we would go to diet and formula supplementation and consider BH4. We would not start pegvaliase in the pregnancy because it takes such a long time for the induction to get to maintenance, and the side effects, especially those of anaphylaxis, are more severe in the earlier phase of treatment. So in general, more data are needed to make specific recommendations about therapies for maternal PKU. One of the areas that we need to understand more about is tyrosine supplementation. It's unknown whether we should supplement tyrosine in a pregnancy if the tyrosine is low. Most centers do supplement. About a third of our patients on pegvaliase have hypotyrosinemia. American College of Medical Genetics, as well as other groups, have recommended supplementation of tyrosine when low. But again, this is expert opinion. We have no data to support recommendations. Finally, it's unclear if pegvaliase dosing will require changes during pregnancy, and that information will unfold with time. Women will continue to have unplanned pregnancy. That we can be sure of. Ideally, if we can treat all PKU girls and women to allow a normal phenylalanine level on unrestricted protein, and that medication is safe to use in pregnancy, then if there is an unintended pregnancy, that fetus would not be at high risk for maternal PKU embryopathy. Thank you very much for your attention.